Recording played. Thank you.
At first, I would like to thank very much for this kind invitation from Professor Hari Krishnan. It's a shame I cannot be there in Malaysia, but at least I'll try to contribute online. So, my topic in this very important conference will be what you need to know to identify the food at risk related to diabetes. I am Ermelinda Pedrosa. I am endocrinologist here in Brasilia, capital of Brazil. I am vice president and regional chair of the DFood for SACA region, also vice president physician for the International Diabetes Federation, and I have the honor to chair the research center at the FIPEX and endocrinology unit here in Brasilia for the health secretariat. I am also a researcher for the Oswaldo Cruz Foundation, which is a very important foundation linked to the Ministry of Health. And I have been president of the Brazilian Diabetes Society, and currently I am its government relations. I have no conflict of interest. And perhaps first, I would like to ask what you need to know at first. We have to consider the impact of the diabetic foot ulcers in people with diabetes. As many people know, 19 to 34% of people with diabetes may develop a diabetic foot ulcer in their lifetime. And unfortunately, each 20 seconds, a lower limb is lost in the world due to diabetes. So we have this photo of this 40-year-old woman with diabetes, which was amputated and she lives in Vietnam. So we really have to put our efforts to avoid this situation. We can see from the picture that this lady lives in a probably poor environment, and this is something very important to consider as well. So the recent IDF Atlas report showed that there is a wide global variation in diabetes related food complications. And this is due to different definitions, diagnostic methods, population characteristics, and also collect and assess data and of course provision in the organization of service. It seems that according to the data, that the peripheral arterial disease estimates were only found for several African countries, South Korea and Australia. And the IDF Africa and SACA regions had the higher frequencies of diabetic peripheral neuropathy. But one thing that was very intriguing is that the IDF Southeast Asia region showed the fewer diabetic foot complications. And I believe that you can discuss this point during this very important conference. So the definition of the diabetic foot involves infection, ulceration, or destruction of tissues of the foot associated with neuropathy and or peripheral arterial disease. And I think we have to consider knowing how to investigate neuropathy and or peripheral arterial disease because these are the most important risk factors. And apart the diabetic peripheral neuropathy, we have to consider also the pseudomotor dysfunction, which is very much neglected, and consider more something that should not be investigated, but they are the lesion in the skin are really previous dysfunction and contributes to ulceration as well. So then comes the deformities, which is the later stage of the diabetic neuropathy, trauma, the peripheral arterial disease, as I said, and the history of diabetic foot ulcer and amputation. Others are diabetic retinopathy, diabetic kidney disease, which is a very, very important factor to consider, and the low socioeconomic situation, deprivation, and the fact of living alone and having inaccessibility to the health system. More recently, the American Diabetes Association, this very important work conducted by Professor Pop Buzui and colleagues, have shown that the social determinants of health, the SDOH, have perhaps have a very important contribution to the peripheral neuropathy and also for the contribution of its complicated, which is the diabetic foot ulcer. We know that the only 50% of people with diabetic neuropathy respond to treatment, and we have also to consider intervention, more social, political, and psychological peripheral um, neuropathy causes. And also we have to consider that 50% of these people do not have symptoms. So it's very, very important to access education, to access the economic stability, social and community context, the neighborhood, and the healthcare and access because these are very, very important issues to consider in this very important permissive factor, which is the neuropathy. So this very important cartoon by our friend Dr. Davy Armstrong has shown that the diabetic foot ulcer is a concert of complications. So we have the neuropathy as the main permissive factor. We have the peripheral arterial disease, which favors especially amputations, and of course infection, which contributes to as a complicating factor. So we have to understand these very important points to understand how someone has a risk factor for diabetic foot ulcer. So as is essential permissive factor, the polyneuropathy, the diabetic peripheral neuropathy, favors the biomechanics deformities and the trauma, and the peripheral arterial disease would be its evolutive factor, and also an amputation ends as in this very important syndrome known as the diabetic foot. And we have to understand that the complication is the infection is a complication factor, and it's present in about 50%, 55% of the patients. So when we look at the diabetic peripheral neuropathy, especially the chronic sensory motor, we have to understand that there is a damage in both large and small fibers, the A, beta, and alpha. And the main outcomes ranges from pain to deformities, which is the late stage, as I said, and insensitivity also falls. We have the pre-ulcerative lesion as anhidrosis, ulcers, infectious amputation, even death. And of course, depression, bad life quality are linked to these outcomes. This important cartoon in this recent work by David Armstrong, Andrew Bolton, and Bas Sickle showing a very interesting way that everything started with the callus formation when we consider the neuropathic foot ulcers. And due to the repetitive external minor trauma, we have again then the subcutaneous hemorrhage coming from the trauma here in the forefront aspect of the foot. And if we don't make any intervention here, unfortunately, this trauma is going to end in a very important foot ulcer. This is complicated with the peripheral arterial disease and also by the infection. How can we identify the foot at risk? So the first important is to assess the foot exam. So we have to remove the shoes, socks, and sandals and do the foot inspection. And you can have these cartoons in the all serial editions of the International Working Group on the Diabetic Foot Practical Guidelines. So we see here the typical neuropathic foot. We see here this something that can be considered as a charcoal foot, the deformities on the dorsal aspect. We have to remember that the valgus is not a proper diabetic complication, but it contributes to ulceration, the medial and the lateral aspect of the foot. And here we can check all the most important areas of plantar pressures. And in the recent years, the Diabetic Foot International has edited in a very nice way the info cards, which help to help people, the healthcare professional, to understand how to examine the food deformities in a person with diabetes. As we can see in these figures, we have the hallux abductus valgus, the claw 2, the hammer 2, the metatarsal head prominence, and the shark foot deformity. So I really invite you to go in our website and see this collection, which is very nice, and this is very easy to display in the foot exam room. The preulcerative lesions related to this autonomy involve the hypohidrosis and anhidrosis, which involves the skin, which is dry, but also the cracks and the fissures that can turn into ulcers as well. How can we screen the diabetic peripheral neuropathy? Simple tools. The vibration with the 128 tuning fork handle. Also, the toothpick to investigate the small fiber C to assess pain. And also you can use the pinprick to consider if the patient is discriminating the tactile sensation. Also, for the large fiber, we can use the vibration tuning fork 128 hertz, and we have to display here in this between the proximal and distal hallux phalanx. So you can have this also in the practical guidelines of the IWGDF guidelines. So for the annual screening, in terms of neuropathic ulcer risk, we can use the 10-gram monofilament. Importantly is to say that this does not give you the diagnosis of the neuropathy, but the neuropathic ulcer risk. And these are the areas that are recommended by the IWGDF, the hallux, the first and the fifth metatarsal head, but many other scientific associations, including the American Diabetes Association, and also many other societies in the world, including the Brazilian Diabetes Society, we have added the third metatarsal head as another site of test for the 10-gram monofilament. And again, the Diabetic Foot International has also the info card for performance of a sensory foot examination. So you can have here the monofilament application, also the vibration tuning fork, and again here, when you don't have either the monofilament or the tuning fork to understand if the person has or not the neuropathic foot risk, you can use the Ipswich touch test, which also investigate the presence or absence of light touch sensation. It's something very simple. We have to use our own fingers to test the hallux, the third toe, and the fifth toe, and see if the patient has can feel the sensation of your own finger touch. So again, I invite you to go through this info card in a very detailed way, because you can display in your foot room, and this is very important to help one to investigate the neuropathic risk of ulceration. And if someone is not used to do the application of the 10-gram monofilament, the International Working Group on the Diabetic Foot Practical Guidelines has the addendum for the sensory foot examination related to the simvastatin monofilament, which is the 10-gram monofilament, and you can learn from that. Also, this is the Brazilian monofilament that we use here in our country. And it comes from a non-government organization which produces this very nice monofilament in a very careful manufacture. Also, in the practical guidelines, you can learn how to use the 128 hertz tuning fork. Again, you have to read very carefully and then try to repeat the recommendations. And finally, you can also learn how to do the light touch test by reading